Good morning, good afternoon, and good evening to all of you, my friends. Unfortunately, I cannot come to this Cairo, Alexandria, and Egypt meeting because of the situation in the Middle East. And I miss you all, my friends. As usual, every year, the meetings in Egypt has fantastic scientific content. And I thank Professor Ivan Fakhri and Professor Suleiman, my two good friends, and others for the wonderful meeting that you're going to have. I wish you all success. Next year, positively, I'll be there with you. And I have no financial disclosures. Thank you. These are a few pictures of what are the legs with non-healing and so-called ulcers. And some of them are healing, some of them are not healing. So when we went ahead and analyzed. So most of these chronic venous ulcers are secondarily infected, unlike what they say in West. In our Middle East countries and South Asia, they are usually infected. And if you take a transverse ultrasound picture, this is the picture. So we have to take a microbiology sample, and I will show you how to take a microbiology sample. It should be the aspiration fluid near the ulcer under ultrasound control, and then send it for culture. Then another issue which develops in these patients is ankle and knee joint arthrosis in chronic venous ulcers. So foot muscle and the calf muscle pump does not work, and physiotherapy is the key here, not compression. This is how the medial compartment of the knee gets affected, and then effusion happens in the knee. And once the effusion is there in the knee, the popliteal vein gets compressed, and the perforating veins, some of them give away. So be very careful in addressing this in knee physiotherapy. So what are static foot disorders? This is another reason why the ulcers don't heal. The static foot ulcers is the ankle movements are restricted. The foot muscle pump does not work. And the foot muscle pump does not work, then the calf muscle pump does not work. And that is why the perforator incompetence and deep vein hypertension is there. One of the main causes why these ulcers don't heal. So admit all these patients for evaluation systematically. You might have done so many things, and the patients will do so many things in the house, and nothing will work. There is a mismatch, something like the Middle East war. So basically, try to understand the anatomy of the foot and the leg. Both the posterior tibial tendon and the tibia and the anterior tibial tendon and the peroneus tendon gets inserted into the foot. So eversion, inversion deformities are there, and what is known as the anterior compartment syndrome. So we have to understand this. So what I do is, and what is available in India in a few centers like mine is, we do an artificial intelligence scanning of the foot. There we find out whether there's an eversion deformity of the foot or inversion deformity or a pes planus or a pes cavus, etc., etc. I'm not going to much detail on this. You can go into that yourself or come to me privately. So some of these legs show up like cellulitis, recurrent, etc., etc. So what you should do is get a proper evaluation done. You will find that there may be some AV malformation or a flow deformity. On both the left side and the right side, you find these problems. So what I do is I treat those first, and you can get a good healing like this. Of course, the skin unfortunately has been near totally damaged. So we need to balance the skin problems later on. These are secondary skin problems. They are not CVA problems. Always address the deep vein hypertension and the PTS, post-thrombotic syndrome. And there is a huge amount of equalization of pressures, and when perforator incompetence is there. So whenever there is a perforator incompetence, go for the perforator by closure by foam, preferably that is what I do. And in the long term, by perforator closure by laser or any other technique. Now I'm reiterating the foot muscle pump, which has to be physiotherapy to start with as soon as the edema is decreased in the foot. For this, the patient has to be admitted, and the physiotherapy has to be done morning and evening by trained physiotherapy just in the vascular and venous phlebology department. So, what are the complications? Very simple. Compression bandage should be applied very carefully. You see this bulle here. So, compression bandaging in these patients should be the third line of management. First line is physiotherapy. Second line is control of infection. Third is the perforator closure or closure of the CVI creating veins. The morbidity of the disease, inadequate management, necessary logistics support, and prolonged continuous care makes the disease a public health burden. Remember, it is 90 venous diseases account for about 90% of vascular diseases. Thank you so much. There's a take heart message. Never give up. There is always a reason. Go behind the reason. This is my bibliography. And I come from this country, God's own country, that is Kerala, the southernmost tip of India. I hope some of you will visit me soon. Thank you.